All right, guys, here we are. Oops, I'm back. Hopefully my voice will hold out to finish up this lecture. So hopefully this one will be a little better than yesterday. I felt like I was all over the place. First time I've tried to record a lecture, I just had notes all over and had trouble finding what I needed. So hopefully second time is a little better. Okay, so we have one more type of shock. I don't think my voice held out for me to talk about obstructive shock yesterday. So, obstructive shock. Basically, we're talking about blood flows obstructed, and you're going to have decreased cardiac output because of it. So, oftentimes, this would be like an abdominal compartment syndrome or some kind of abdominal pressure that's pushing on the inferior vena cava. You could even have this with like a PE. So once again, we need rapid assessment and rapid treatment. Um, you're going to have restricted diastolic filling of the right ventricle from the compression that you'll see on that vena cava. So I did put the patho map on here. Once again, very similar to the other ones. Um, so you're going to see a lot of the same things as well. You're going to see basically you might see like jugular venous distension. You might see a rapid pulse and basically similar signs and symptoms of many of the other types of shock that we already talked about. Um, so next, well, let's talk about this case study real quick. It doesn't really help to do a case study when you guys are not with me, but we'll give it a shot. So we're going to talk about this guy a couple different times throughout this lesson, I believe. So we have a 26-year-old man arrives with multiple gunshot wounds to the abdomen. You see his blood pressure, we know is obviously low, heart rate's really high. So we want to know what type of shock is he experiencing. So based on his vital signs, hopefully you thought about hypovolemic shock. So what other clinical manifestations might you anticipate with him? So continuing on, we see that his heart rate is continuing to increase. Now it's 188. His blood pressure is 50/30. He's had no urine output since admission. His bowel sounds are hypoactive. His skin is cool and clammy. What stage of shock is he in? So we haven't gotten to the stages yet. So that's what we're going to talk about next. He'll be in the compensatory stage. And then what compensating mechanisms are working to maintain his cardiac output. So we're going to talk about that here in these next slides. So in the stages of shock, the initial stage, oftentimes you're not going to see a whole lot. A lot of the changes are at the cellular level, going from aerobic to anaerobic. Your lactic acid is going to start to build up. The liver needs to work on removing that. And that process requires oxygen, which, as we're seeing, is unavailable due to the decreased tissue perfusion. So that's the first of 4 stages. So the second stage is where we're looking at the compensation, where the body's trying to deal with what's going on. So there's a lot of different ways the body can do that. We're going to start seeing the body start to reflect the imbalances in oxygen supply and demand. And you can see that in like neural, hormonal, biochemical. The body is attempting to overcome, basically maintain homeostasis. So this stage is when you're really going to see the blood pressure drop. This is because we have the decreased cardiac output. You're going to see a narrowing of the pulse pressure. And then basically you're going to see those SNS symptoms. So let's see if that's on the next slide. Yep. So You're going to see that vasoconstriction to the vital, or so that we can keep blood to the vital organs. So the heart and the brain are going to be obviously the focuses. Um, you're going to see an increased rate and depth of respirations. Obviously, we're shunting blood, um, and sometimes, well, we're shunting blood away from a lot of the other organs. So, like we've talked about multiple times, um, we're going to have the impaired GI motility as the body is taking blood away from the bowels and a lot of the um, organs in the abdomen. We're going to have slowed peristalsis. Obviously, we're going to have a risk for ileus because of that. A lot of these patients are going to have cool, clammy skin, except septic patients sometimes will have the opposite and they'll be warm and flushed. Um, our our body's going to convert angiotensin 1 to angiotensin 2. We're going to have vasoconstriction. We're going to have increased venous return to the heart. And then this in turn is going to stimulate the release of aldosterone. And then you're going to have increased sodium reabsorption, which stimulates ADH. So I know you guys have talked about all that in the past, and I know those are a lot of like big words, but I think you understand that whole process, hopefully. So you're going to have all of that happening in these situations of shock. Um, so if the cause of shock is corrected fairly quickly, the patients are going to recover with little to no residual effects. But if the shock is not corrected, you're going to keep having more and more effects of the decreased perfusion and blood flow. Um, so, next slide here. Oh, okay. So then the progressive stage, I guess we'll move on to that. So the progressive stage is when the body is no longer able to compensate for what's going on. So you're going to have obviously a lot of the features of decreased cellular perfusion. You're going to have altered capillary permeability. You're going to have leakage of protein into the interstitial space. That's a tongue twister. You're going to have increased interstitial edema, and you're going to see a lot of altered mental status in this stage. Patients are going to be in the ICU. They're going to need advanced monitoring and treatment. Cardiac output is still decreasing. You're still seeing a decrease in blood pressure in this stage. Okay, so still on the progressive stage here. You're going to have, like I just talked about, with the protein leaking, and you're going to have lots of edema, lots of hypoperfusion. The anoscara, you're going to see the fluid leaking and how that affects the solid organs and the peripheral tissues. You're having decreased blood flow to those pulmonary capillaries. You're going to see the weak peripheral pulses because of the hypotension. You're going to start seeing ischemia of the distal extremities. You're going to start seeing dysrhythmias because of the dysfunction myocardium, myocardial ischemia. You could even see just complete MI. And then ultimately, you're going to have complete deterioration of the cardiovascular system as things progress. Let's see what else. So you can read on the slide, but the fluid's going to move from the pulmonary vascular to the interstitium, and then the fluid's moving into the alveoli as well. So we have a lot of the respiratory issues because of that. You're going to see pulmonary edema, you're going to see bronchoconstriction, and then decreased functional residual capacity, as well as you have that edema. Along with the respiratory stuff and the edema, you're going to have decreased surfactant, you're going to have tachypnea, all of these things. You're going to see crackles, obviously, like we mentioned. All these things are going to increase the work of breathing and just continue to progress until we're able to hopefully fix the cause and then stop the shock. So this is still the progressive stage. You're going to see issues with the GI system, the mucosal barriers. After a while, you're going to start seeing ulcers, GI bleeding. Patients won't be able to absorb nutrients because of the hypoperfusion. You're going to have kidney issues. A lot of the drugs that we're giving during this time are also nephrotoxic. So not only do we already have kidney issues because the body is not sending, perfusing the kidney as well, but then you have these nephrotoxic drugs that the body is unable to, or the kidney is unable to break down appropriately. And so it's just a domino effect. And the liver, I'm sorry, I'm kind of talking about both of them here, but honestly, it is both. There are drugs that both the kidney and the liver are working on, and both of them are hypoperfused. So we're going to start seeing decreased urine output. We're going to start seeing elevated BUN and creatinine, and we're going to start seeing metabolic acidosis. And as the liver fails to metabolize drugs, you're going to start seeing jaundice. You're going to start seeing elevated enzymes. You have risk for DIC and significant bleeding as the liver continues to lose function as well. So the fourth stage is the refractory stage. And this one is kind of the last stage of shock. So you still have the decreased perfusion from the vasoconstriction, from the decreased cardiac output. Your lactic acid is really going to start to accumulate and contribute to even more increased capillary permeability. You're still going to have the fluid in the plasma leaving the vascular space, moving to the interstitial space. Blood's going to pool, and things are just continuing to progress. Let's see. Cerebral blood flow cannot be maintained at this point. You're going to have cerebral ischemia. You have the really profound hypotension, hypoxemia, your liver's still failing, your lungs and kidneys are not working appropriately, you're accumulating all of the waste products, basically your organs are just completely failing. The lactic acid is going to be really high. You're going to continue to get tachypnic, and your organs are completely failing. So at this point, recovery is becoming more and more unlikely, and you are really in trouble. So let's talk about some diagnostic studies. Obviously, the first one is pretty much always the history and physical. And then there's really not one particular thing that we're looking at for diagnosing shock. There's not one test that's going to be a really great indicator. So we're going to do blood studies. One of the big ones, maybe not the main one, but one of the big ones we're going to look at is an elevate of the lactic acid. You might see a base deficit. You're going to do an EKG, chest x-ray. You're going to have them on continuous pulse ox, hemodynamic monitoring, all that good stuff. So back to our case study with our guy. He received 3 units of blood, EKG, chest x-ray. He's going to the OR so they can take out the bullets. What other interventions would we want to do to prevent this shock from progressing? So let's talk about that a little bit. So some of the main things we're going to do for all of these shocks is we're going to make sure the patient's responsive. We're going to make sure, obviously, airway, try to make sure oxygen delivery is good. We are going to try to control or eliminate whatever could be causing decreased perfusion. We're going to try to do whatever we can to protect the organs from dysfunction, and obviously try to determine a cause here. As far as oxygen ventilation, we're obviously going to optimize cardiac output with fluid replacement drugs, or drugs we're going to transfuse to try to get that hemoglobin up. We're gonna give supplemental oxygen, often on a ventilator, just to really be able to increase that arterial oxygen. And then just do what we can to manage the O2 supply and demand for them. And then for the septic, hypovolemic, and anaphylactic shock, we are always focused on volume expansion. That's going to be one of the very first things that the emergency room is going to do is just fluids, fluids, fluids. Sorry, I don't know why that line is in there twice, but we do have to base that determination on some other things. So you're always going to see a couple large bore IVs or an IO access or a CVC. You're often going to give those isotonic solutions, so normal saline or lactated ringers. Sometimes you're going to give the blood, and then you're going to be basing these amounts on, all the vital signs, the perfusion pressures, capillary refill, neurostatus, skim temps, urine output, all that kind of stuff. So you do need to watch for some things as you are pushing large volumes of fluid. If the fluids are cold, you need to watch out for hypothermia. And then another thing to think about is that red blood cells don't contain coagulation factors. So sometimes you may need to give something in addition or along with the red blood cells if you're giving really large amounts because you don't want them to have issues with bleeding because of that. You may need vasopressors if hypotension continues after we start replacing the fluids. And then we have the drug therapy. And our primary goal is just trying to fix the decreased perfusion. So one of the problems is that many of these drugs have a lot of the vasoconstrictor properties that can be harmful if the drug does leak into the tissues. And so we do have to watch out for that in these shock patients. So one of the main ones we're going to end up using is the vasopressors, but often we do reserve those for patients that don't improve with the fluid. So they'll try fluid first, and then they will move on to the vasopressors. You're going to see vasodilators. Basically, we're going to try to get our MAP greater than 65, and then we're just going to keep monitoring the blood pressure and all those pressures and everything to make sure we're not fluid overloading. Okay, here's just a fun picture that I liked, and I won't go through it too much. It's a lot of what we've already talked about, but I just like, I don't know, as you can tell, I like pictures. So I'll just let you kind of look at that on your own. But yeah, a lot of the treatments for a lot of the types of shock are going to overlap, and most of it's going to be applicable to all the different types of shock. Okay, so like we've been talking about the nutrition therapy, we really want to get that started right away. So sometimes they'll start enteral nutrition within 24 hours or just like a slow drip, just to keep the bowels awake and working. Usually they're not doing like TPN or anything unless they really can't tolerate some kind of enteral nutrition because that's always preferred. And the other reason for that, besides keeping the bowels awake, is that you have this hypermetabolism, and so that really is causing protein and calorie malnutrition. The body needs as much ability to fight what's going on as it can, so it needs the calories to be able to do that. If patients are well nourished in general, they don't need a ton though. We're not trying to feed them a normal amount. We're just trying to give them enough to overcome that hypermetabolism, and then, like I said, to keep their GI tract perfused. We will usually weigh patients daily, and we'll monitor those labs as well. So specific to cardiogenic shock, overall, we want to, restore blood flow to the myocardium, make sure we have a good balance between O2 and supply and demand. Sometimes these patients are going to go for angioplasty and they're going to have stenting. They might need emergency revascularization. They might need valve replacement. I'll just try to fix the cause. And then as far as drugs for them, um, we're going to, be focused on optimizing perfusion and then reducing the workload of the heart. So you might see the nitrates, you might see the diuretics, um, vasodilators, and the bioadrenergic blockers to help reduce the heart rate if necessary. You may see some circulatory assist devices. I don't think you probably need to know a whole lot about those, but you could see them. And then patients may end up needing heart transplant depending on how far we go. So specific to hypovolemic shock, obviously we're focusing on stopping the fluid loss and then restoring the volume. Um, there is a rule that you might want to be familiar with. That's kind of a protocol, and that is the calculation of using the 3-to-1 rule. So 3 mils of a crystalloid fluid for every 1 mil of estimated blood loss. So back to our friend with the gunshot wound. So he had surgery, they took out the bullets, repaired some blood vessels. Surgeon estimated he lost 3 liters of blood before surgery, 1 more drink. So what fluids would we give to stabilize his blood volume? So like we talked about, probably the LR, the normal saline, going at a 3-to-1 ratio. He's intubated, has a central line and an art line. His blood pressure is a little bit better, heart rate's a little bit better. CVP is 7. Um, so thinking about medications that he might take, um, a lot of the stuff that we just talked about. So I won't go over that again. I am starting to lose my voice already. So I'm going to move on. I don't need to repeat, but there is a good table in the book with some of those medications as well. Okay. All right, I can do this. So septic shock, once again, we're talking about the fluid replacement. Initially, they start with 30 mils per kil of an isotonic solution, vasopressors. You're going to see the epinephrine. Sometimes you're going to see IV corticosteroids if the vasopressors and fluid therapy don't work to maintain adequate blood pressure. You're going to see broad spectrum antibiotics started right away. And then after cultures are obtained, you'll see more specific antibiotics ordered based on whatever they find. For septic shock, you really want to keep the glucose levels down. You really want to use those proton pump inhibitors to make sure patients aren't getting stress ulcers, and the VTE prophylaxis, like we see with almost everybody in the hospital, is definitely going to apply to these septic shock patients as well. For neurogenic shock, you're obviously going to focus on the spinal stability. That's going to be one of your first thoughts with the neurogenic shock. Obviously, you see some of the meds are going to be very similar. You're going to see the atropine and vasopressors. You're going to use fluids a little bit more cautiously, as in this case, the hypotension isn't related to fluid loss. It's usually related to the other stuff going on. So you kind of got to be careful and really monitor. And usually your first step in a neurogenic shock is not going to be to push fluids like it might be with the hypovolemic shock. So that is definitely one difference. You're still going to watch for hypothermia, and that's not as much because of the fluids that you're pushing, but just because the hypothalamic dysfunction and they're not able to regulate their blood pressure as well. So anaphylactic shock, also a little bit different than the others. The patho is more similar, but what we're going to do is quite different. Epinephrine is oftentimes the first drug that we're going to give, but sometimes for patients, even just like a Benadryl or diphenhydramine, will work, or even like a famotidine will sometimes take care of some of the initial anaphylactic shock that's not too severe. But our main focus is going to be on that patent airway because of the swelling. We just want to make sure we catch that right away if it is starting to swell and the patients are starting to have trouble breathing. You're going to use nebulized bronchodilators. You're going to use even aerosols, like epinephrine as an aerosol can be used. And then oftentimes you are going to have to intubate or even do like um, a, a trach or a cric because of that swelling. So sometimes if we don't catch it right away, it's too difficult to intubate because of all that swelling. So that's where you're going to have to see more aggressive measures to make sure we're maintaining that airway. Um, yeah, that's probably good with that. So the obstructive shock, obviously early recognition and treatment, um, mechanical decompression. If you're looking at like the PE issue, you're obviously going to start some heparin or some other kind of thrombolytic therapy to break up that clot. If it's like a mass, you're going to see the radiation, debulking, maybe even surgery to remove the mass, and just any way you can to decompress. So you might even just see like um, them going to IR to have, fluid drained or whatever the case may be. So back to our friend, his airway and breathing are doing well. He is on a ventilator. His incisions are dry and intact. Blood pressure and heart rate are pretty good. So what other things do we want to think about for him? So he's kind of out of the woods now. Things are looking up. And now what are some of our focuses? So we're continuing to monitor the tissue perfusion. So we're going to continue to look at the peripheral pulses. Obviously, we're checking vital signs, making sure level of consciousness isn't changing, checking for cap refill, skin temperature, urine output, all that good stuff. So we're keeping an eye on all that. We're, now that we're kind of out of the woods and able to breathe for a second, we're looking at his health history. We're going to check about, medications, any recent travel, just anything else that we would need to know that we just kind of had to skip over at first to really make sure that he was doing okay. Um, so it looks like AM's mother and girlfriend arrive. His mother tells you has a history of GERD, but otherwise he's healthy. Um, so clinical problems. Um, we've kind of already talked about this, but I did want to point out table, let's see, 42.1 um, is a good one to look at. So that's back a little ways in this chapter. But take a look at that. It's going to show some of the nursing diagnoses and just some extra information. So um, we'll talk a little bit about it here. So some of the diagnoses that you might be focused on are the adequate tissue perfusion, restoring blood pressure, organ function, avoiding complications from the hypoperfusion, and preventing any healthcare associated complications. So making sure we're not having skin breakdown, making sure we're not having falls as they get back up and walk, trying to prevent pneumonia by all of our respiratory interventions. So all those things that we do with every patient obviously are a focus for these patients as well. So our friend continues to stabilize. He's extubated, recognizes his family, has lots of questions. So then we start to think, well, like, what else can we do for him to support him as he starts to get into the later stages of his recovery process. So we're going to continue to keep an eye on neurologic status. We're checking it every 1 to 2 hours at the beginning, and then as it progresses, we're going to move to every 4 hours. We're checking cardiovascular status, all these things, making sure that we don't have heart murmurs that are popping up or dysrhythmias. We want to, reduce noise and light levels in the ICU. But then as they start to get better, we do want to start keeping them on a day-night schedule. That's always going to help patients to prevent delirium. Respiratory wise, we're monitoring all these things that we've already talked about. Renal status, we're keeping an eye on that urine output and that creatinine level. We talked about body temperature, GI, and then we do need to focus on turning the patients, make sure they don't get pressure sores, starting passive and active range of motion whenever we can. We want to be doing the oral care. We want to be supporting them even emotionally. There's going to be a lot of anxiety, fear, They even have pain. And then even addressing like spiritual needs and trying to involve caregivers. Um, just as simple as like maintaining privacy or making sure their call lights and reach, all this kind of stuff is just important for every patient and just something to think about. Like we are always so focused on like, oh, what's the blood pressure? Well, what if the patient doesn't have their call light, or what if they get a bed sore because we didn't turn them? So just keeping all that stuff in mind is really huge, especially as both of you guys are going to a general floor. A lot of times those are going to be the bigger needs for your patients. But we do want to keep an eye on the emotional level or emotional support for the patient. There's lots of anxiety, fear. Um, so yeah, I think I already talked about all that. So here is a question. When assessing a patient in shock, you recognize hemodynamics of shock include. So look at these. Are you going to have normal cardiac output and cardiogenic shock? Are you going to have increased CVP and hypovolemic shock? Are you going to have increased systemic vascular resistance in all the shocks? Or are you going to have variations in cardiac output and decreased systemic vascular resistance in septic shock? So the answer is D. So with septic shock, remember we have the vasodilation, the maldistribution of blood flow, we have the myocardial depression. Patients, might be normal volemic. They might have hypovolemia, and they might also have hypotension. It just kind of depends what's going on, some of the reasons, what stages they're in. You are going to have a decreased ejection fraction for the first few days. So therefore, your ventricles are going to dilate to help maintain that stroke volume. And that's going to kind of resolve by about 7 to 10 days. So probably good. Okay, one more question here. Nurse is caring for a critically ill patient. You suspect the patient has progressed beyond the compensate. Oh man. Yes, you got it. Stage of shock if what occurs. So what are you keeping an eye out for with this? So you could see potentially any of these, but um, the answer they're looking for here is the potassium level, because when we have acute kidney injury, when we have the acidosis, we're obviously going to see the increased potassium. All right, we have a patient with septic shock. Which change would you expect? I'll let you read those real quick. All right, so hopefully you have an answer. So which change would you expect? You are going to expect D. So going back to this, patients in septic shock are going to have the decreased vascular resistance, decreased EF, decreased mean arterial pressure, and the decreased central venous pressure, the preload, you're going to have more often in the hypovolemic or obstructive shock. Okay, I'm going to give my voice a break and then we'll talk about SIRS and MODS.